أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
Jazakallah. Now I will hand over to Dr. Muhammad Awais, then he will proceed.
Assalamu alaikum, and thank you to the Orthocon team for giving us this opportunity to present. So I will be first talking about the systematic approach to MRI in knee. Later, Dr. Amin will be presenting a small talk on MRI of the menisci, and followed by that, I would be presenting MRI of the articular cartilage. So I am working as senior instructor and section head MRI at the Department of Radiology, Aga Khan Hospital. I have nothing to disclose regarding this presentation. So we will first very briefly describe radiological anatomy. What are the basic routine MRI sequences? What is the basic approach, how you should interpret an MRI knee, and few common pathologies that I would like to share. So let's start with the basics of anatomy. And I will just be focusing on the major structures that we need to evaluate in a systematic knee MRI. So you should be evaluating the menisci, the cruciate ligaments, that is the anterior and the posterior cruciate ligaments, the collateral ligaments, those are the medial and the lateral collateral ligaments, the articular cartilage involving the patellofemoral as well as the femorotibial compartments, then the extensor apparatus, which includes the quadriceps tendon and the patellar ligament, then the bursae around the knee, muscles and bones. So this is a diagrammatic representation of MRI knee, and I'm sure that everyone would be knowing this, but just for the sake of refreshment, this is the cruciate ligaments. We have the anterior cruciate ligament, which attaches anterior to the tibia. Then we have the posterior cruciate ligament. We have the menisci, and we have the medial and the lateral collateral ligaments. This is the coronal image, and this is the sagittal image. On the sagittal image, we can appreciate the distal quadriceps tendon, the patellar ligament. These are the cruciates, and these are the menisci. And this is the Hoffa's fat pad in the suprapatellar bursa. So on MR, this is a coronal section, and it is taken from the level of the distal condyles, and this one. And here you can appreciate that this is the femur. The cortex appears jet black. So every compact bone will appear jet black, whereas the marrow has high signals on T1 as well as T2. So this is used to evaluate bone-related pathologies. And here we can see that this is the anterior cruciate ligament. This is the posterior cruciate ligament, which are seen arising from the intercondylar notch at the respective areas. And this is the menisci. So this is the lateral meniscus. Along with that, here we are not seeing the lateral collateral ligament because the section is taken a bit posteriorly. So I will be showing an interactive case in which I will be showing all these structures in the approach, how to approach the MRI. This is the medial collateral ligament. It should be uniform thickness and jet black in color. So these are the structures that we evaluate on coronal image. This is an axial image of the MR knee, and here you can see the patella and the patellar cartilage. So this black line is the cortex, and posterior to it is the patellar cartilage, which is iso-intense as compared to the bone. And this is the femoral cartilage. Again, so these are very normal and of good thickness. Then this is the lateral collateral ligament as well as the iliotibial tract, which is at the lateral aspect of the knee. Then this is the vastus muscles. This section is taken from the distal condyles as well. This was the level of this section. So these are the vastus muscles, then the popliteal fossa, the muscles around the popliteal fossa. So on the medial aspects, we have the pes insidianus muscles and the tendons. And on the right, we have bicep femoris, which attaches alongside the iliotibial tract. So further down, this is at the level of the menisci, and you just can appreciate minimally the menisci on this image. Here we can see that this is the site of attachment of the anterior cruciate ligament. This is the site of attachment of the posterior cruciate ligament. Again, we can better visualize the muscles lower down. These are the popliteal vessels, artery and the vein. And this is again the lateral collateral ligament, which is more clearly visualized here, and this is the medial collateral ligament. Now coming to the sagittal images, this is the sagittal image. So this is the medial meniscus. You start from a lateral approach and then you move towards medial, more medial aspect. So this is the medial meniscus. So it is more thicker posteriorly as compared to anterior. It's a triangular structure, and it should be jet black without any signals, hyper intensities within this. This is the distal femoral condyle and the tibial condyle, and again we can appreciate the articular cartilage around the knee. This is a more medial image, as you can appreciate from here. This is the posterior cruciate ligament, which is curvilinear shaped structure, and it attaches posteriorly to the tibia. As we go more medially, here we can appreciate the anterior cruciate ligament, and it attaches anterior to the tibia. And you can appreciate the patellar cartilage again here. This is the distal quadriceps tendon, and here you can appreciate the patellar ligament. Now coming to the basic MRI sequences, so every institution have their own specific sequences that they follow, and there is no single universal accepted protocol. However, a usual protocol will involve a T2 weighted image, a PD weighted image. So this is a T2 weighted image in which fluid is black. This is a corresponding PD fat sat image, which you can see that the fat has been suppressed, and you can appreciate the articular cartilage here, and there is a large osteochondral defect here. So this is a PD image and a T2 weighted image. Compare this with this image. This is a T1 weighted image. In T1 weighted image, the fluid appears iso or hypointense. So this is a T1 weighted image. It is more better for visualization of the anatomy. And this is a T2 stir image in which you can see that the fluid is very bright. So it is basically a very high, heavily weighted T2 weighted image with suppression of the fat. So this kind of overestimate ligamentous or cartilaginous injury, but it is very good for depiction of any bone edema or marrow edema. So now coming to how we actually approach an MRI knee when it comes to us. So there are certain sequences that should be followed. So there is no universal approach, but that is the approach that I follow. So you start with the coronal image, and then you proceed from center to the periphery. That is an inside out approach. Then I follow a sagittal. Then on the sagittal image, you start from the medial aspect. You trace the medial collateral ligament, the medial meniscus. You move towards the center of the knee and then towards the lateral aspect. Finally, I scroll down the axial images from superior to inferior, look at the distal thigh muscles, then the quadriceps tendon, then the patella, then patellar ligament. So scroll from superior to inferior and find out what pathologies you are finding. And then always evaluate the pathologies on two sequences, on two planes, not a single plane. So let me show you an example of the systemic approach through an interactive case. This on the left hand side is a proton density PD weighted image with fat suppression. On the right hand side, this is a T1 weighted image without fat suppression. And here you can appreciate that fluid is bright on a PD fat sat image as compared to the T1 weighted image in which fluid is dark. So my approach is to start from the center of the film, look at the bones, that is the femur and the tibia, look for any signs of bone bruise, edema, fracture, any focal bony lesions. So here are these tiny T2 and T1 hypointense foci. So these are small bone islands. As we come anteriorly, here you can appreciate a large T2 hyperintense focus, which is low on T1. So this was a large osteochondral defect. There's some significant loss of the cartilage. And these are the cruciate ligaments in the intercondylar notch. So this is the lateral, so this is the anterior cruciate ligament, which is arising from the lateral condyle, and it attaches on the tibia anteriorly. So here you can see the tibial spine. This is the posterior cruciate ligament, which is arising from the medial femoral condyle, and it attaches to the tibia posteriorly. Here you can see the fibular head. So lateral femoral condyle has an irregular shape, which is reckoned with the face in profile or the Kimelon sign. And medial condyle is more smooth in its appearance. So that is a sign how you can differentiate between the medial and the lateral condyles. Then these are the menisci. You can see the triangular shape, which are jet black, and there should be no abnormal signals, no cutoff of these of its margins. And you should also look at their roots where they are attaching to the tibia. And then you move to the periphery, you start appreciate the lateral collateral ligaments, then the medial collateral ligament. So here there are few signals at the femoral attachment suggesting partial thickness tear. So we start with the coronal image. Then we move on to the sagittal image. So this is a proton density sagittal image. So here you can appreciate the distal quadriceps tendon. This is the patella. This is the patellar cartilage. I will talk more about this in detail on my talk in the patellar cartilage. This is a ligamentum patellae, and you can see that there are multiple T2 hyperintense signals here, which is suggestive of tear of the patellar ligament. And then again, you can appreciate the large osteochondral defect with loss of cartilage at the femoral trochlea, and there is joint effusion. So you can start with the center and you can move to one side, or you can start from, for example, this is the medial aspect of the knee, and here you can appreciate that this is the medial meniscus, and this is the pes insidious tendons. As we move towards the center of the knee, then you can appreciate the posterior cruciate ligament. This is the anterior cruciate ligament, this one. So you can appreciate that there are some abnormal signals here near the tibial attachment suggestive of a partial thickness tear. And then you move further towards the other side. So you can appreciate that this is the the lateral meniscus, and this is the fibula. So you see these structures again on the sagittal images, and then you correlate them on an axial image. So this is an axial image, and you can see that this is the distal femur. There's joint of fusion in the suprapatellar bursa. This is the distal quadriceps tendon. As we go down, you can appreciate patella, and this is the cortex. As we go down further, you can appreciate those tiny bone islands. These are the cruciate ligaments which are arising. So this is the anterior cruciate ligament, which is anteriorly located and it attaches to the tibia anteriorly. This is the posterior cruciate ligament, which arises from the lateral aspect and it attaches to the tibia posteriorly. These are the collateral ligaments. So this is the medial collateral ligament, and this is the lateral collateral ligament alongside the iliotibial tract and the biceps femoris head. So this is how you approach from superior to inferior on the axial, from medial to lateral on the sagittal images, and from center to outside on the coronal images. And this is important that you correlate whatever you see on your findings on the axial or the sagittal on other planes, so that you are able to appreciate the exact location and extent of the pathologies. And it is important to look at every structure on all of these sequences so that you don't miss anything. So let me go back to my original presentation. So starting with the coronal images, inside I have to approach, then the sagittal images, medial to lateral approach, axial images, superior to inferior approach, and then correlate findings on the multiple planes. So menisci, Dr. Amin will be talking about the menisci in detail, so I will be skipping this portion. So cruciate ligaments, again, there are anterior and the posterior cruciate ligaments. I will be just showing some pathologies related to the major structures. So for the sake of completion, so this is the anterior cruciate ligament, which is intact, quite homogeneous, except for a few signals at the tibial, which are normal. So you expect to see some signals here, which is due to the technique that the MR is acquired. But here you do not see the anterior cruciate ligament, and it was a complete tear of the ACL. So complete ACL tear. This is the normal PCL ligament, which has a curvilinear course, but here you can see that there is buckling and there is tear of the posterior cruciate ligament. This is the medial collateral ligament. It should be jet black, homogeneous alongside the femoral and the tibial condyles, but here you appreciate that there are diffuse abnormal signals with thinning of the medial collateral ligament at the tibial site of attachment. So this was tear of the medial collateral ligament, which was involving both the superficial as well as the deeper fibers. This is a case of this is a normal lateral collateral ligament. It should be jet black, arising from the distal femur and attaching to the fibular head. But here you appreciate that this has become thickened and there is discontinuity of the fibers with T2 hyperintense signals within it. So this was a lateral collateral ligament tear. Chondromalacia patelli, I will be describing this in my talk on the patellar articular cartilage. So I will skip this. And these are multiple loose bodies. So you can have numerous loose bodies, synovial osteochondromatosis. This was a case of multiple loose bodies. Here you appreciate that there is some fissuring of the bone at the site of the tibial tuberosity with some fluid and hyperintense signals. So this was a case of Osgood-Schlatter disease with edema in the underlying bone. So this is hyperintense signals in the bone. This is a post-contrast image. So here you can see that there is diffuse enhancement of the synovium and the tibial and the femoral condyles. So this was a case of tuberculous arthritis. Here you see that there is diffuse thickening of the synovium with sharp erosions having overhanging edges, and there are soft tissue foci, enhancing foci in the subcutaneous tissue. So this was an inflammatory arthritis that was gout. So again, you can see that this is a large cystic structure at the posterior aspect of the knee with communication with the popliteal region. So this is a large cystic popliteal cyst, that is the Baker cyst. Here you see that this is the anterior cruciate ligament, and there are multiseptated T2 hyperintense signals in relation to it. Here on the coronal image, again, we can appreciate, and this is in correlation with the PCL as well. So this was a ganglion cyst of the posterior cruciate ligament. This is the medial collateral ligament, and alongside this is the pes insilinus bursa. And again, you can see some T2 multiseparated cystic structures in relation to it. And this was a case of pes insilinus bursitis. And finally, also look for any bone lesions that you may encounter. For example, there is a soap bubble, lytic exmensile lesion, well corticated, narrow zone of transition, which is showing diffuse enhancement. So this was a neoplastic lesion, which was the ganglion cyst. So the take-home message is always have a systemic approach so that no important structures are missed, and you evaluate the bones, the soft tissues, ligaments, menisci, as well as surrounding soft tissues for any lesions, signs of degeneration, trauma, infection, inflammation on neoplasm. Recognize the signal characteristics on various MR sequences, because that is important. Some things might be bright on T2 and these may be normal. So you need to recognize what are the various normal characteristics of the structures on an MR, and then use multi-plan reconstructions to confirm your findings that you picked on a certain sequence. Okay, thank you. So if you have any questions, you can just write them down in the chat box and we can discuss that after Dr. Amin's talk. Thank you.
Thank you, Dr. Awais.
Assalamu alaikum. Bismillahirrahmanirrahim. My name is Dr. Amin, and I will be discussing more focused talk on the meniscal imaging and meniscal tear. Dr. Awais has covered the anatomy very clearly, so it might allow me to shorten my lecture basics on the specifically on the anatomy. And I would like to thank you, the Orthocon team, and Dr. Awais for allowing me the opportunity to participate in this talk. So these are the three images which I would like you to make a mental note of. And the objective or the take-home message will be, again, these three images. And if you would be able to identify these three images at the end of this talk, it would be a good achievement for me as well. So starting from the news, the meniscal injuries are pretty common are seen in the different sports-related injuries, and Pakistani team has been suffering pretty much from these meniscal injuries. So this is the news where Usman Khwaja has a meniscal tear, and he was out from the Indian series from Pakistan. Okay, so the outline will be describing the anatomy and the collagen structure of the meniscus. Then we'll discuss a bit about the MRI interpretations. Then the most three common types of the tear, which I would like you all to know. So the basic function of the meniscus is that it's going to provide a congruence or a structure to support the round femur condyle on the flat tibia. And it acts for the shock absorption, load transmission, and some stability, but it is not a primary stabilizer of the knee joint. And if you see this small video, what I would like you to see is that these are the two structures. This is the lateral meniscus. This is the femur, this is the tibia, and this is the patella. Now, if you see that the inferior surface of the femur is rather rounded, whereas the tibial surface is relatively flat. So make it possible for the femur to glide over the tibia. So there are now these two structures, which are known as menisci. Now, this is the medial meniscus, and this is the lateral meniscus. And the important thing is that this part of the meniscus, which is now colored in a light blue tone, this is the vascular part or the outer part of the meniscus, which is being supplied by the blood, whereas the inner part of the meniscus, which you can see colored now. So this is a avascular zone, which is also known as white zone. Now these part now, which these are colored with the blue, these are the anterior horn, these are the posterior horn, and the part in between these two is the body of the meniscus. Now I would like to just make sure that you understand these four areas. Basically, this is the lateral meniscus and the medial meniscus, and these are the root attachments of the menisci through which the meniscus is firmly attached with the tibia. And now the structure, which is outlined now in light blue, these are the arcuate fibers, which also sort of attach the tibia loosely to the, attach the meniscus to the tibia as well. So now, starting with this image, you can see that the root of the root attachment are shown. These are the medial meniscus. 1 and 2 are the root attachment for the medial meniscus, whereas 3 and 4 are the root attachment for the lateral meniscus. Medial meniscus has a relatively widened shape, whereas the lateral meniscus is more closely packed along the medial edges. Now this picture is important because we will be discussing the tiers of the menisci based on this image. So what I want you to appreciate is that there are two structures of the collagen which are more randomly organized, whereas the deep structure, this part of the, this part of the meniscus, these are more bundled fibers which are having a relative orientation which is running in a anterior posterior dimension. Like these fibers are running from this way and going all the way back, whereas there is another fiber which is invaginating into it, and that is known as radial tie fibers. These structures or these collagen bundles are strongly held and they are very much hard to break. So the tiers of the menisci are going to respect these bundles, and we'll see eventually how they are going to form. Now this image is again a presentation of the same image, and these red images are the cylindrical circumferential longitudinal bundles, and this white structure is the radial tie fiber. This is an image just to show you how the blood supply is entering the meniscus. You can see this is the peripheral part, and the peripheral part of the meniscus is supplied, and this is known as the red zone, whereas the white zone is the part more medially, and it has no major blood supply and is avascular. This is a cadaveric image just to make sure what is the relationship of the white zone with the red zone. So normally the white zone is going to contain approximately somewhere around 75 to 90% of the total width of the meniscus, whereas this is the red zone, this part which is only like a bit brighter red. The outer part is not the meniscal structure at all. It is going to be the synovial attachment to the meniscus and will not be counted as a part of the meniscus. Now this is the MRI structure or MRI image of a meniscus. You can see that these is having a superior margin, an inferior surface, and a medial free edge, whereas laterally you can appreciate that there is a hyper-intense area. This hyper-intense area is not the part of the meniscus. This is just the attachment of the collagen and the capsule, and it is not counted in any part of the meniscus. This only the black area is the meniscus, and you will only appreciate the tears in this region. Now for the medial meniscus, I'll just take it shortly. Like the anterior horn is going to be like 7.7 millimeter, whereas posterior horn is going to be 10.6 millimeter. These are just an approximate values, but what you need to appreciate is that in the medial meniscus, the posterior horn is going to be relatively larger than the anterior horn, and we'll be appreciating these in the images as well. Now, these are the few structures, and Dr. Abbas has already discussed it, so I will be passing these through. So this is like just the posterior horn of the medial meniscus, and this is the anterior horn of the medial meniscus, and you can see that the posterior horn is relatively larger in size as compared to the anterior horn. And so these are the other images. And the most medial one, you can see, appreciate an area here, which is just next to the posterior cruciate ligament. This is the part of the attachment of the posterior root of the medial meniscus. And again, you can see that these are going to attach. And this area is the anterior root of the medial meniscus, or the attachment site of the anterior root. So again, another news. So Umar Gul was out of the ICC Champions Trophy, where MRI confirmed a full thickness tear of posterior horn of the medial meniscus with a patchy bruising on his right knee. So it always keep making news from especially from the sports side. So then now we'll just discuss a bit anatomy of the lateral meniscus. The important thing is that the anterior horn of the lateral meniscus and the posterior horn are all approximately same in size, but in this case, the body is relatively large. So you can appreciate that the anterior and the posterior horns are approximately similar in size, as is going to be the case in this one. This is the lateral meniscus, this is the posterior horn, this is the anterior horn, and you can appreciate that not much difference in the length or the width of the menisci is seen. So I will skip these anatomy images, and this is Yasir Shah, and he had a tear for the lateral meniscus, and again was dropped from the team for like 4 or 5 weeks again. So now, starting with the basics of the tears of the menisci, this is the same image. For the tear to be called as a true tear, the abnormal signal area, there are two criteria basically. One is that either the shape of the meniscus is abnormal, like in this image, or there is going to be an abnormal signal within the meniscus. So for example, like if you see this image, so there is a disruption of the normal tapering of the meniscus. So this can indicate a meniscal tear, and if abnormal signal is reaching the surface. Now for the surface, I will go back to this image. So this is the superior surface, this is the inferior surface, and this is the free edge. So for a tear to be called as a tear, it has to be reaching 1, 2, or 3 of these places, either one of them. But the peripheral one, that is not considered a surface for the tear. So if abnormal signal is touching this area, so that is not called a tear as such, but these are relatively myxoid degenerative changes, or sometimes some contusion of the meniscus can indicate in this way. So if you can see this image, this is an MRI image, so you can appreciate that there is an abnormal signal within the meniscus, but instead of reaching superior, inferior, or medial free edge, you can appreciate that this signal is touching all the way to the lateral side. So this is more like a grade 1, grade 2 tears, but those are considered not a true tear, but rather a degenerative change. Whereas now, if you appreciate this image, you can see that there is an abnormal signal which is extending all the way down to touch the inferior surface of the meniscus. Now, if this is touching the inferior, superior, or the medial aspect, that is now called a tear, or that is known as a grade 3 tear, which needs further treatment but there is an issue here. If you can see this abnormal signal area in only one slice, then what is the possibility that this is a true tear or is not a true tear? It depends on which side of the meniscus you are going to see the abnormal signal. So if it's only on one signal, or one image, sorry, and it's going to be approximately 50% time correct that it's going to be a true meniscal tear, whereas in the lateral meniscus, it's associated with 30% of the true tears. So it can be more abnormal in the lateral meniscus. So if you can see, so you in these cases, normally what you can do is like you can just ask them to follow up after a certain time, like 3 months, and to see if the signal has gone away or still stays there. Now coming back to the structure which we have discussed, and you can again appreciate that these are the longitudinal bundles, which are tough bundles and hard to break. Similar, this is the graphical representation of the same bundles, and you can appreciate the circumferential longitudinal bundles, and this is the radial tie fibers. Now these are the 3 basically main types. The 4th is only the a bit oblique radial tear, which is also known as flap tear. So we'll discuss these two together, whereas the vertical tear and the horizontal tears, these are going to be discussed separately. So these longitudinal word is a bit confusing, so you can just use vertical tear and a horizontal tear and a radial tear. These three terminologies should be more familiar and more commonly used. So in the case of longitudinal vertical tear, or exactly the vertical tear, what happens is you have an axial loading. Now you know that these are the strong structures. They are very hard to break. So what happens is that the damage is extending between these fibers in an anterior posterior direction, and which is resulting in a tear which is just like this. So you can see that the longitudinal fibers are running all the way anterior posteriorly, and the tear is extending between those fibers rather than traversing those fibers. So now what two important thing in this tear, which is the vertical tear, is that it is normally found in the outer one half of the meniscus. And the second, it sort of maintains a distance from the periphery. Like if you see in this area, the distance from the periphery is going to be almost the same as we extend along the tear. But the important thing, there are variations that it can go inside as well, but this is the most common pattern of the vertical tear. Now I'm going to show you one image. You can see these are the contiguous slices. Now, if we start with this one, so this is a tear. In the next image, it's almost respecting the same distance. Again, it's going to respect the same distance, and again, it's going to respect the same distance. So what you see here is this is the medial meniscus, and the posterior horn of the medial meniscus has a defect or abnormal signal, which is extending all the way vertically from superior surface to the inferior surface, so sort of splitting in this part the meniscus into two halves. So this is another image. You can appreciate again that there is a sort of abnormal signal area, which is extending from the superior surface to the inferior surface and respecting the distance from the periphery. So this indicates that those collagen fiber bundles, the tear is in between them rather than traversing through them. So that's why the distance is maintained. So this is a simple vertical tear. Now, when we come to the horizontal tear, which is the second type, so the force is more like a shear force rather than an axial loading or a compression force. So what happens is, like, now you apply the force towards this direction. Rather than applying a vertical force, this is now going to be a horizontal force. And this is going to result in what? A sort of a defect which is going to run horizontal to the meniscus. These are again, those same longitudinal fibers, and this is going to be the traversing or the path of the tear. And this is a graphical example of the same tear. So it's going to extend, might be from medially or could be from the center and extending all the way to the periphery, or can stop anywhere. And this is going to split the meniscus in upper and lower parts rather than in medial and lateral divisions. It can, especially if it progresses in the medial, but still the more, this is going to be the horizontal tear. This is going to be a graphical, like an image of an, again, meniscal tear of the medial meniscus. And if you can see that this defect is going to start from all the way inferior surface of the meniscus and extending all the way to the periphery, sort of splitting it in the half. And as Dr. Vass has mentioned again, that it should be homogeneously jet black. So you shouldn't be expecting this much of an abnormal signal within the meniscus itself. One more important thing associated with the horizontal tear is, like, now if you create a path from this side to the periphery, so what you expect is that there could be a small cyst associated with this tear along the lateral side. So if you see a tear, meniscal cyst, it is highly associated with the horizontal type tear. And you can see the reason that it can communicate with all the way through the meniscus to the periphery. There are certain cases where the tear is not reaching the free edge, but still the fluid produced within the meniscus due to some reactive changes can accumulate and extend all the way to the periphery to form a cyst. So you can appreciate on this MRI images that there is a split and there is a cyst, meniscal cyst with it, associated with it. This is another same case where you can see a tear, horizontal tear, extending through the meniscus, and there is going to be a cyst sitting just next to it. Now, the last type of the tear is going to be the radial tear. Now, in this case, what you see is that the force is applied in such a way that it's going to traverse through the bundles. Like instead of running through in between the bundles, now it's going to dissect in center of the bundles and can separate these bundles apart. So what you expect for these bundles are holding the meniscus in anterior posterior dimension. So if you sort of cut them in between, so they are going to be separated. The margins can be separated from each other. So this is an image of a radial tear. And you can appreciate that this is a defect which is running not in a longitudinal dimension rather than in a radial way, and is breaking them apart. And the second thing is that we had seen that the longitudinal vertical tear was running in the periphery, whereas the radial tear is normally seen in the inner part or near inner half of the meniscus. And we have already seen that the inner half of the meniscus is, or inner part of the meniscus is avascular. So it takes more time and needs sometimes more effort for the radial tear or the inner half tears to be repaired by themselves. So one more finding what you see in the radial tear is like that instead of having a smooth tapering along the medial edges or the inner edges, you can have an abrupt cutoff of the free edge of the meniscus. And you can appreciate the same finding on this MRI image. And you can see that instead of having a smooth tapering, you can have an immediate defect which is sitting in between the free edges. This is another case, and you can again appreciate that there is an abrupt tapering of this part of the meniscus. This is relatively smooth, but however, this is going to be abruptly cut off, and then you can see a defect in this case as well. This is an axial section, like you are cutting through the defect, and if you can appreciate, this is the meniscus which is running from anterior to the posterior, and you can see a defect which is running all the way to the periphery. Through this defect is some fluid which is communicating. So now the technical thing in this case is like if you are going to image, say from this way, so what you're going to see is like you can see at least one half of the horn of the meniscus, but one part of the meniscus is going to be missing in this case. For example, I'm going to show you this image. So what you expect in this image is that there is a persistent anterior part or anterior horn of the medial meniscus, whereas the posterior horn of the medial meniscus is missing, and you can see that there is once you cross medially to the PCL, you should be seeing the posterior horn of the medial meniscus. So there's no posterior horn of the medial meniscus. So this indicates that the radial tear is passing through that area, and that part is being splitted into two parts, and the that slice of the MRI which is crossing through it is showing a missing fragment or the missing part of the meniscus. So this is another indication of the radial tears. So these are the two examples of the radial tear again. So this is relatively a closed radial tear which is extending from the medial edge into the lateral part. And again, this is the same or similar types radial tear where the two parts are readily separated from each other. The flap tear, which is sort of an oblique radial tear. So what you need to appreciate is that in contiguous slices, the area or the position of the tear is going to migrate, like in this image when I'm going to cross in this area. So it is going to be more towards the inner edge, whereas now the next slide, which is going to cross, say, in this region, it has moved towards the outer side. For example, now this is an oblique tear or a flap tear. So you can appreciate that in this image, the tear is more towards the free edge, whereas as I cross to the next one, it is going to be migrating towards the outer side or the outer away from the free edge of the meniscus. So if you see these migrating sort of meniscus, so this is going to be indicative of a flap tear. So now what I'm going to do is I'm going to show you a few cases, and based on the information which I have given you, you are just going to make a simple guess. Either you can just type in a chat box, or you can just make a mental note and I will tell you the answers. So in that case, what we are going to do is we are going to review the meniscal tears so that you can just remember how these are going to show. So this is going to be the first case, and what do you think this tear is? Then I will explain. So what's happening here is that there you can see a defect which is running from the superior surface to the inferior surface and dividing the meniscus into two parts. And we have seen that this is the vertical longitudinal tear or vertical tear, which is going to run in this way. So this was a vertical tear of the posterior horn of the lateral meniscus. So this is going to be the next one. Just have an idea what do you think this tear is. Now you can appreciate we have seen that in the outer parts, like this one, in the outer half, if you see a defect, it's more likely going to be a vertical tear, whereas when you come to the inner side of the meniscus, these tears are going to be radial tear. And what happens is that if you see this meniscus, you see it's going to taper in a very smooth fashion. You can even appreciate the tip in this region. Whereas on this side, on the lateral side, what you see is that there is going to be an abrupt tapering of the free edge, and this is the radial tear in this region. So this is the next case. Okay, so this is going to be, again, what a tear which is extending from the superior surface to the inferior surface and along the lateral side. So this is again going to be a vertical longitudinal tear. Which one is this one? Okay, so what is happening here is that you can see a defect which is almost running from the free edge of the meniscus, extending into the periphery, separating these two parts in a radial fashion. So this is going to be a radial tear. This is another case. So what you see in this one, this is again the free edge inner part, and that's going to extend to the periphery, and this is again a radial tear. So now what about this case? Okay, so in this case, what's happening here, that there is an abnormal signal area which is extending from the inferior surface of the meniscus and extending horizontally towards the lateral side. You can appreciate this, although it's not extending all the way to the periphery, but it's extending this way. So this is going to be a more like a horizontal tear, which was the second variety of the tears. This is another one. So what you're seeing again is that there is a defect which is running from the superior surface to the inferior surface and is partially separating these part of the menisci. And you can appreciate that this is going to be a vertical tear again. This one. So this is an abnormal area which is extending all the way from the free edge. You can't clearly appreciate that defect, but it's extending from this way to all the side to the periphery. And there is another cyst which is associated with this tear. So the cyst is almost usually associated with the horizontal tear. So this is the horizontal tear which is extending all the way towards the periphery with the perimeniscal cyst. Now this is a tear which is shown in axial section, like you are cutting through the tear. So what you appreciate in this is that there is a defect which is running in a longitudinal fashion, not in this area, just indicating that what is the path of the meniscus. So this is the defect which is extending in this way. So if you see a defect in the peripheral half of the meniscus and it's running in a longitudinal fashion, so this is going to be a vertical longitudinal tear, but this is in an axial image how the vertical longitudinal tear is going to show up. So just remember these images as well. So what's this one? Okay, so this one is again very simple defect which is extending from the superior surface to the inferior surface, separating almost like or dividing it to a bit some extent. So this is again a simple vertical longitudinal tear. So you can appreciate now that there is a defect, which this is the normal meniscus, by the way. So you can appreciate a defect which is extending, say, from the inferior or the free edge of the meniscus all the way to the periphery, and then you have an associated cystic structure, which is the meniscal cyst. So this is another horizontal tear associated with the meniscal cyst. Now this is again a defect which is more towards the outer half of the meniscus, and it is running in more in an anterior posterior dimension in longitudinal fashion. So this is again a vertical longitudinal tear of the meniscus. Again, another defect which is extending all the way from the superior surface to the inferior surface, separating this part of the meniscus. So this is going to be another vertical longitudinal tear. So another one where you have a defect which is running all the way from the inner part to the outer part, or almost into the outer half of the meniscus, but it's extending all the way to the inner edge as well. So this is a radial tear. Now this is a case where the meniscus has been split into two halves or two parts, in which one part has migrated medially into the intercondylar notch, whereas a small part is sitting on the its original place. So what is this type of the tear? It is known as bucket handle tear, obviously, but the type is the vertical longitudinal tear. So it's a more extensive variety of vertical longitudinal tear, where the tear is so extensive that it splits it into two halves or two unequal halves or unequal parts, and then one part is migrated into the intercondylar notch. So remember that the bucket handle tear is also a vertical longitudinal tear. Now this is again a case of a vertical longitudinal tear in this area. And what's this one? You remember that whenever you have an abrupt tapering of the free edge, it's always going to be a radial tear. And this one, is again a vertical longitudinal tear, another vertical longitudinal tear, another one, and this is again an axial of a vertical longitudinal tear. So you can appreciate that this is a defect which is running longitudinally along the length of the meniscus and is separating it into two halves. Okay, so these are now 5 images. Still just a few, 1 or 2 more images to show. So now you will have to appreciate this region only. So where the arrow is there, what you see here is an meniscus. Then what happens? The meniscus starts to disappear, 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 and then there is a meniscus again. So again, you see a meniscus, no meniscus, almost no meniscus, again no meniscus, and then the meniscus appears again. So you remember which type of tear this was, where you are going to find an unset part of meniscus. So this is going to be a radial tear where you can extend all the way to the periphery. You can see this is the same image as well. So you have a defect within the part of the meniscus, which is going to represent in this way that you can see an absent part of the meniscus. So this is a radial tear. And this is again an axial image of the same patient, where you can see that these two edges of the menisci are separated. And when the images or the slices were crossing through this region of the MRI, so that you were not appreciating any meniscus in this region. So remember, if you find an absent part of a meniscus, like there you're seeing a normal anterior horn when missing the posterior horn, so it's more likely going to be a radial tear, and you should be searching your axial images more vigilantly. This is radial tear again, obviously, because it's the free edge which is involved. You can see it's very smooth free edge on this side, whereas anteriorly there is a abrupt tapering of the free edge. This is an horizontal tear, obviously, because it's extending all the way from the free edge up to the periphery. This one is more like a, this is the free edge, and this is more like a radial tear. So you see that this, if you see a more signal area in the free edge part, so it's going to be a radial tear. And this is again an axial slice, which is showing you a radial tear extending up to the periphery. This is again a radial tear. And now the take-home message, I showed you 3 images at the start. So now you're going to help me decide which tear is this one. So what do you think? This is the vertical longitudinal tear. So which one is this? This is the radial tear. And this one, this is the horizontal longitudinal tear, or horizontal tear, you can simply say. So this was the objective of this talk, was to just that you can just simply identify how the tear looks and what's the definition of the tear, and how to appreciate at least these 3 tears, which are vertical and radial as well as horizontal tear. So thanks a lot for listening. You can just send your questions if you have any to Dr. Wes or the chat, and then we can have your questions at the end.
So thank you, Dr. Amin. Very informative talk and multiple cases. So let me now present my final presentation on the MRI of the articular cartilage. So I will be talking about the MRI of the articular cartilage, and that will be including the patellar articular cartilage as well as the tibiofemoral cartilage. So I have no disclosures to, no conflicts of interest to disclose. And this is the layout of my presentation. So I will be briefly talking about anatomy, then what are the various MR sequences that we usually perform, how do you grade the patellar articular cartilage injuries, what are the different types and the cases, then some of the newer techniques to map the image of the patellar cartilage, and finally the take-home message. So this is the patellar the articular cartilage. So it covers the inferior aspect of the femur, the articular surfaces of the tibia, as well as the articular surface of the patella. And this is on the MR sagittal images. You can appreciate this as iso-intense structure just posterior to the patella in the region of the distal femur. This is the region of the femoral trochlea, and this is the tibia. So on it appears as a spindle-shaped elongated structure, which is relatively wider in its lower half and then tapers towards the superior and the inferior poles. It is relatively iso-intense, and it should be homogeneous without any abnormal signals. Patellar cartilage should be differentiated from the bone. So this tiny black line, if you appreciate here, is actually the thin cortex of the bone, which separates the medullary cavity from the cartilage. And this is the surface of the cartilage. So this is a normal appearing patellar cartilage. There is slight thinning here, but otherwise no abnormal signals within this cartilage. So histologically, there are multiple layers of the articular cartilage, starting with the superficial layers, and you can appreciate the orientation of the collagen fibers as well as the chondrocytes. So there is a superficial layer which is compact, so you see that as a tiny hypointense line. Then there is an intermediate transition layer, deeper layers. Then there is a tide mark, which is the interface or the junction between the non-calcified and the calcified portion of the cartilage, and below that is the compact and the subchondral bone. So this is the basic anatomy, the microscopic anatomy of the cartilage, and it is not possible to view all of these layers on a conventional MR, but with high resolution, you may be able to differentiate superficial from the deeper layers of the cartilage. So as I talked before, the cartilage has different appearance on different sequences, and the usual sequences that are used for mapping of the cartilage are the T2 and the PD weighted images, the T1 weighted image, and the SPGR flash image. So let me show you an interactive case in which we just look at the appearance of the cartilage on these sequences and the pathologies. So let me just Okay, so this is an axial PD weighted image, and this is the patella, and this is the superior pole, and you can appreciate this is the distal quadriceps tendon. And as you go down, this iso-intense structure, which is in between the fluid, so its signal intensity is between fluid and the bone. So this is an iso-intense structure. Look at it's fairly homogeneous, smooth. We do not see any gross defect here. So this is the normal signals of the patellar articular cartilage. This is sagittal PD image. So again, you can appreciate that there are few signal changes here, but rest of the cartilage looks fine, and it is iso intense as compared to the bone. You can appreciate the subchondral bone here. This is the femoral cartilage at the trochlea, and you can appreciate here it is fairly smooth here, no abnormal signals, but so it's fairly smooth, and there are no abnormal signals here. So this is the normal appearance of the cartilage on PD image. This is an SPGR or a flash image. It's basically a T1 weighted image. And here you can appreciate that the bone is dark, and this very adequately shows the articular cartilage. So you can appreciate this dark line as cartilage. So the bone is dark, the fluid is dark, and the menisci is dark as well. The only thing which is bright here is the cartilage. So this is a sequence which is specifically used to map the thickness of the articular cartilage. So you can appreciate the cartilage here. The only thing is, if there is degeneration within the cartilage, that will appear as a hypointense signal, so it may miss gross tears or something. So for evaluation of the tears, the conventional PD sequence is better, but for the evaluation of the thickness of the cartilage, the SPGR sequence is better. So let us go back to our presentation. So we have discussed the appearance of the cartilage on the various sequences. And now how do we grade the articular cartilage injury? So this is a modified outer bridge grading system. And there are basically 5 grades. So grade 0 is when the cartilage is smooth. It is of uniform thickness without any abnormal signals. So that is a normal cartilage. If you start to see some abnormal signals within the cartilage, but the contour or the margins of the cartilage is intact, then that is grade 1 chondromalacia patellic changes. If there is some fissuring of the outer margins and there is irregularity, but that is less than 50% thickness of the cartilage, and that is a grade 2 chondromalacia changes. If there is gross fissuring and the thickness is more than 50% of the articular cartilage, then that becomes grade 3. And if there is frank loss of the articular cartilage with denuding of the underlying bone, then that becomes a grade 4 injury. So these are the MR images, and here you appreciate that this is a normal patellar articular cartilage with which is smooth, uniform thickness. The contours are fairly normal, so this is a grade 0 changes. Here, there are abnormal signals in the patellar articular cartilage, but these contours are maintained, and this is of uniform thickness, so this is a grade 1 injury. Here we appreciate that there are abnormal signals, and these are involving almost 50% of the cartilage. So this is a grade 2 injury. As we further go down, again, we can see that there are diffuse abnormal signals. There is gross irregularity of the contours. It is involving more than 50% of the thickness of the cartilage. So this is a grade 3 injury, and if there is complete loss of the articular cartilage with exposure of the underlying subchondral bone, then that becomes a grade 4 injury. So this is a grade 4 injury. and and if there are abnormal signals, T2 hypertense signals in the underlying bones depicting subchondral cystic changes, so that becomes an osteochondral defect, and this is a complication of the chondromalacic changes. So then there are various types of tears. So here we can appreciate that there is some abnormal fissuring and irregularity fibrillation, and this is also extending deeply, but this is not involving the entire extent of the cartilage. So this is a partial thickness tear. Compare it on the right hand side, you can see that there is a fissure which is extending throughout the entire extent of the articular cartilage. There is diffuse thinning of the cartilage at the medial aspect with exposure of the underlying bone. So this is a complete thickness tear. Again you see that there is a large defect here with some bony irregularity in the subchondral bone. So this is a full thickness tear with an osteochondral defect, and here on the sagittal images you can clearly see the bony defect in the underlying bone as well. So this is a grossly abnormal bone grade 4 injury with osteochondral defect. So a fragment can be dislodged of the cartilage as well as the bone. So here we can appreciate that there are multiple abnormal bony fragments in the joint space. So there is loss of cartilage and there are multiple loose bodies within the joint space. So most of the time we may not be able to see those fragments, but sometimes these are visualized. So it is important to look for these loose bodies within the joint, as they may cause complications during walking, and it is important to let the orthopedic surgeon know that there are loose bodies that needs to be taken out. Again, so another type of tear is the flap tear. Here you can see that there is a longitudinal thickness tear which is extending to the deeper surfaces, and it is extending and it is creating a flap of the overlying cartilage, and this is an unstable injury, and this flap can dislodge into the joint space, forming a loose body. So here again you can see a flap injury. This is known as delamination. So there is abnormal hyperintense signals signifying separation of the articular cartilage from the underlying bone. So this is delamination of the cartilage from the underlying bone. So again, this is kind of injury to the articular cartilage. And then the chronic sequelae due to these osteochondral defects and changes to the cartilage, there could be subchondral osteophyte formation. So here you can see that there is bony outgrowth which is filling the osteochondral defect, and it can be fairly large as well. So these osteophytes are secondarily degenerative changes due to these osteochondral defects. So here we can appreciate multiple osteochondral defects. So now coming to some newer techniques. So there has been a lot of research done on how to map these changes of cartilage degeneration before these are apparent on the conventional imaging, because conventional images usually takes time for the changes to appear, and these are at an advanced stage. So the newer techniques are usually used to determine the biochemical changes in the cartilage. So these are not morphological techniques, but more physiological based techniques, biochemical techniques, in which you try to analyze the underlying biochemistry of the cartilage. So these are the T2 mapping, the D-GEMRIC, T1 row, sodium MR imaging, and the diffusion weighted imaging. So D-GEMRIC basically stands for delayed gadolinium enhanced MRI for the cartilage, and this is performed after 19 minutes post injection, and the sequence takes around 7 minutes, but it is not routinely performed and is not currently commercially available, is currently in the research phase. T1 row mapping again is used to evaluate for the proteoglycan evaluation of the cartilage. So in cases of chondromalacia patelli, there is loss of the proteoglycans, and that leads to relaxation of T1 row time. So there are certain relaxation times, T1 row and the T2 relaxation time. So every tissue has their specific relaxation time. So if there is loss of collagen or the proteoglycans, then those changes are apparent on these imaging. So this is a T1 row mapping and T2 mapping. Again, T1 row is currently under investigation and research and is not currently available. However, T2 mapping is commercially available, and this is an image of the T2 mapping. And if there is loss of cartilage, it might not be apparent on conventional imaging, but on T2 mapping, as there are changes in biochemistry, and those changes can be picked out by these T2 mapping. So here we can appreciate that these are hyper intense or red signals of high intensity as compared to the normal cartilage, which is usually greenish blue. So these signify areas in which the proteoglycan or the collagen has been lost. So again, this is a diagrammatic representation, and you can see that there is prolongation of the T2 relaxation time. So the take-home message is articular cartilage is small but important structure which can lead to knee pain, and there is a surge in early recognition of how we can estimate its damage and how to avoid its complications. And MRI offers several techniques for visualization of the cartilage injury at biochemical and morphological scales. And the newer techniques, that is the T2 mapping, also are used to evaluate repair of the cartilage through various agents. Uh, and and the final take-home message actually is, whenever you are looking at the cartilage, evaluate it very meticulously and carefully, because there might be tiny signal changes or tiny fissuring that might be missed, and that may later lead to frank osteocartilage defects and osteochondral defects and loose bodies. So I will share a few interactive cases for the evaluation of the cartilage that I would like to share with you. So let me just share my screen. So this is a case of a lady who presented with knee pain. And if you can appreciate here, there is a small hyperintense signal which is extending from the cartilage into the underlying bone. So this is a subchondral change involving the cartilage with a tiny osteochondral fissuring. As we go down here, if you appreciate, this is the cartilage. There is gross thinning of the cartilage, and there are T2 hyperintense signals which are extending at the deeper aspect of the cartilage. So this is a case of fissuring of the cartilage. If I can show you on the sagittal images as well. So always evaluate. So this is the fissuring that I was talking about. So always correlate findings on both the images. So there are abnormal signals here. There is tiny fissuring here. And if you appreciate here, again, there are some abnormal signals in the underlying bone. There is abnormal signals in the cartilage along with its thinning. As we go down, you can appreciate here, this is an osteochondral defect here. This is an SPGR or a T1 fast echo images. And here you can appreciate that there is thinning of the cartilage here. There are abnormal T2 hypointense signals at the articular cartilage. This one faint T2 hypointense signals. These may be changed. These may be missed. However, you need to correlate them with the conventional imaging. So the PD images, so that these becomes more conspicuous. But this sequence, again, you can see that the rest of the cartilage is fairly normal in thickness, homogeneous, and no other areas of frank loss of the cartilage. So there's one more case that I want to show. So this is a case of the MR knee, and start with the axial images for the evaluation of the cartilage. Here we appreciate that there is slight signal changes in the cartilage suggestive of grade 1 changes, but as we go down, so there are no other gross changes. So just subtle abnormal signals here, which are suggestive of grade 1 chondromalacic changes, nothing else. So these may be easily missed if you're not looking after these. And let me share one more case, one final case. Again, we will start with the PD image. So as we go down, here you see tiny fissuring of the articular cartilage. So you see there is disruption of the cartilage. It is just fissuring. It is less than 25%. So this is a grade 2 injury of the cartilage. However, as we go down, here you start to see that there is abnormality of the femoral cartilage at the trochlear groove, and there is complete loss of the cartilage, and there are subchondral cystic changes in the underlying femur. So this was a grade 4 chondromalacic changes with osteochondral defect. Here again, there are some changes. Appreciate here. And one important thing that we also need to look for are the loose bodies. So if you appreciate here, this is a small hypointense focus in the within the joint space. So this was a small, tiny loose body. Again, another one here as well. So those are important to look and inform your orthopedic surgeon so that these small loose bodies are in their knowledge, and if they want to take it out, they can take that out. Okay. So with that, I would like to thank you all for listening.
So there is a question, if you can see the conversation.
Yes. So there are a few questions. So one of the question is for Dr. Amin. Dr. Amin, there's a question for you. It is being asked that are radial tears also associated with meniscal cysts?
Okay, so hope you're hearing me. So yeah, the horizontal tears or the radial tears can also be associated, but normally they are more complex ones. Like they are just in a combination of like a complex cyst, complex tear associated with cysts. So, but more oftenly, the horizontal tear is going to be associated with an meniscal cyst. But in literature, even you see that there is not significant mentioning which type of the tear was associated with cyst, but they are associated with tears, that's for sure. But there are isolated cases as well, but normally they are usually seen with this some sort of tear.
Yes. So, Dr. Amin, one other question from the candidates. So they are asking, so can we have a combination of the tiers as well?
Yeah. The main issue is like that I had to cover in limited time. So I had to skip a few tiers such as the complex tiers. So complex tiers can be a combination of one, two, or three tiers even. So you can have a tier which can extend in a horizontal way, in a longitudinal way, and can also extend medially and can act as a radial tier as well. So you can see these tiers as well. That's not like exclusively only one tier can be seen at one time. So there can be different tiers which can be seen. A combination basically.
Okay, and one more question is that regarding the grading of the tiers. So how do we grade the tier, and especially how do we differentiate whether that is reaching up to the articular surface or not?
Okay, so in this way, like I will show you the image discussed earlier.
Yes, we can see the screen.
See there. Okay, so now the tear is basically like this is the meniscus. And you can see that there are three main areas, which is the superior one, inferior one, and the free edge. So normally we grade tears previously as grade 1, grade 2, and grade 3. So the grade 1 and grade 2 tears were when so in this case, you can see that the abnormal signal is extending up to the periphery rather than reaching the superior inferior surface or the free edge. So in this case, you can grade these as grade 1 and grade 2. But normally, to say it as a tier, so this abnormal signal needs to reach at least superior surface, inferior surface, or the free edge of the meniscus. Or the other criteria is going to be that you should have an abnormal contour of the meniscus. So this is going to be a tier, this is going to be a tier, but if the signal is just like this, which is extending up to the periphery, so this is not an exclusive tier, so these are normally known as grade 1 and grade 2. Secondly, if you see an abnormal signal which is extending to one surface, and it's on only one slice of the images. So in that case, what happens is like there is a possibility of tear, which is like 50% in case of medial meniscus, but 50% of the time it could be just some error which is showing an abnormal signal extending to the surface. And in the lateral meniscus, it's only going to be like 30% or true tear. So you need to either confirm it in two planes, or you should have seen it in at least two contiguous planes. So that's where you are going to see the tear in more clear way.
Yeah, okay, thank you for that. Just a quick question from one of the candidates, and he's asking, is flap tear and bucket-handed tear the same?
No. The flap tear, okay, let me show you if I can show you a picture of a, so you can see this image on my screen. So what happens is in the bucket handle tear, this is an image on the left lower side. You can see that this is a bucket handle tear. So bucket handle tear, what happens, it is not going to show any abnormal signal extending to the free edge. Rather, it's a vertical longitudinal tear, which is splitting the meniscus from the center into the two parts, where once the part of the meniscus is going to flip and come into the intercondylar region, whereas the radial tear is more like in this direction, like it's going to cross and splitting the meniscus in like an anterior posterior dimension rather than in this longitudinal direction. So that's the main difference between the bucket handle tear. Bucket handle tear is a more complicated vertical longitudinal tear, which is extending all the way from anterior to the posterior part and then separating these two parts away from each other, forming a bucket handle sort of thing. Like this is a bucket and this is the handle of the bucket. So this is a more vertical longitudinal tear rather than a radial tear, which is going to split the meniscus in this part, in this direction.
Okay, thank you. But the question was whether the flip handle tear, the flip tear and the bucket handle tear are the same. Flip tear.
Flip tear can be like, you know, that it's again like you can have an horizontal flap tear.
Yes, so these are two separate.
Separate thing. Yeah, I think you can just have a bucket handle tear as a separate entity. Like it has a segment which is like going all the way medially, but I think like it has a definite name. You can just use that name as bucket handle tear to make it more clear.
Okay, so one quick question from me, and that is, can we have T2 mappings on usual MRI machines? So the answer is yes and no. This is a fairly new technique which has been now commercially available, and it can be performed on 1.5 Teslas as well as 3 Teslas as well, but you have to purchase it separately. So any other questions that anyone would like to ask?
Assalamu alaikum, Dr. Abbas.
Walaikum assalam. How are you,
So
sir?
I just, fine, thank you. Just would like to take this opportunity to thank you and Dr. Amin for this such a wonderful presentation. Though this knee joint is not my primary working area, but I really enjoyed a lot and learned a lot from both of your presentation. Thank you very much for joining us.
Okay. Thank you, sir. So I think with that we conclude. Okay, sir. Thank you. Thank you all. Allah Hafiz.